Audio Jungle.
Every sunset brings the promise of a new dawn. A very pleasant good evening to you all. I honor to welcome you all to our beloved Dr.M.Ganesaratnam Memorial Lecture 2022 on Surgery Beyond the Scalpel, proudly conducted by the Department of Surgery, Faculty of Medicine, University of Jaffna. I kindly request you all to stand for 2 minutes silent prayer. Once again, ladies and gentlemen, I kindly request you all please remain standing for a while. Once fire is lit, the darkness flees away. So, next will be lighting of traditional oil lamp. For the lighting, I cordially invite the following dignitaries. First of all, I cordially invite Professor S. Srisatulraja, Vice Chancellor, University of Jaffna. Next, I personally invite our chief guest and orator, Dr.Satish Kumar Goonesinghe, President, the College of Surgeons of Sri Lanka and consultant urological surgeon. Next, I kindly invite Professor R. Surendra Kumaran, Dean, Faculty of Medicine, University of Jaffna. Next, I kindly invite Dr. S. Gopashankar, Head, Department of Surgery, Faculty of Medicine, University of Jaffna. Finally, I kindly request one of the family members to lighting the oil lamp. Thank you, madam. Thank you all. Please be seated. Now, I am extremely happy to invite Vice Chancellor Professor S. Srisatulraja to introduce our orator to the audience.
First, let me pay my respectful obeisance to the Almighty. So we are always recalling Alanganavanda Amrisedane Adi Toletum Silandan Perimudia. So we recall him by remembering the sacrifice the Almighty made for the betterment of our life. So the Creator's best influence on the nature as well on the human being is the time influence. So time brings people together. Time also separates relationship. So we are the human beings, are the feeling machines. And among all the feelings, it's the one hard to bear it, is the feeling of separation. So Dr. the eminent surgeon, Ganesaratnam sir, joined with us in the teaching hospital as a senior consultant in 1989. During that time, maybe 6 months before, a cold-blood killing of pediatrician Shobha Sundaram sir was there. Somasundaram, Somasundaram, Shobha Sundaram. So, just imagine, foreign security forces, army was here in the name of peacekeeping, that there was a conflict, broke out, and everything was disarray in this Jaffna Peninsula. During that time also, we lost Rajani Kirnagama in this university vicinity. So in this time, Dr. Ganesaratnam joined the teaching hospital, and that time there was nobody there to carry out the normal surgical survey of the service of the people. Plus, as a teaching hospital, we had to do with so many professorial engagement. More than that, the pathology, anatomy, and everything was depleted. And there was a time in the Senate even the medical faculty, senior people, some of them put a paper for the closure of the medical faculty for some time. At that time, our Dr. Ganesaratnam came as a divine grace for our rescue and rendered service till 1995, single-handedly managed the teaching hospital as a guiding the teaching hospital. Maybe some junior people were helping him. And top of that, he was an excellent teacher and towering personality. He inspired a lot of people. He's improvised the methodology of delivering the service in trying circumstances and deliver. And then, of course, 1995 exodus, he moved to Colombo. Then we will commence the activities here. So he decorated almost all the position in the surgical, as a professional surgeon. And eventually he was the president of the College of Surgeons of Sri Lanka. Today, to glorify his remembrance and his family, our Madam is here, Ganesaratnam Madam, and their family actually wanted to inaugurate this commemoration. And willingly our university also wanted to have this. So it is a topmost remembrance for us to pay our respect, and also it's going to be an inspiration for others to follow how a professional can deliver best of his service by sacrificing a lot of his personal welfare and personal upliftment. So in this regard, so this commemoration lecture is a very fitting one, and the gentleman today going to deliver the commemoration lecture is the Satish Kumar, an All Indian. This is all called Malasagara's, one of the schools, Nalanda, Ananda, Mahanama, and series of schools, indigenous set up in the Buddhist culture. They put up these schools in the sequence of Nalanda, Dharma Bala, and all these schools. And our schools also, Jaffna Hindu, also same years, 125 years. Now they are shown to the world that they can produce best of best professionals from our indigenous setup. Those days, it was a bit of a thing. We had to seek or import things from the other sort of setup. So the Nalandian, our today keynote speaker, keynote orator of this commemoration lecture, Satish Kumar Goonesinghe, is a multi-talented personality. He was recognized even from the school days as an all-round student, all-round performing student. He was got the award. I will go through that one in a moment. And also, more than a surgeon, in his setting in the forensic field also he might be very valuable. He's a qualified lawyer, and he's in the Bar Association, the Open University of Sri Lanka. He got his law degree, and more than that, any person, any human being, the culture is important, where we belong to, because we all are our genes coming from many thousand years of evolution. And he got a Master of Arts from the University of Kelaniya in the Buddhist culture. So you imagine a person, a practicing surgeon with so many accolades, doing 3 degrees on top of this PAGM and board of certification and all this. It's something very unique and commendable. So ladies and gentlemen, I have pleasure in introducing the orator. Today, Madam Satish Kumar also here. I welcome them, and Professor Dr. Ganesaratnam, Brother Law, Professor Mohanas, our Chancellor, Varonia University, also being present here. I really want to welcome him, and our Emeritus Professor and the former Vice Chancellor Balasundarala sir, and all the surgeons now decorating the service realm of our teaching hospital. Most welcome, and the students and the friends and the colleagues of the Dr.M.Ganesaratnam. Most welcome extended from on behalf of the University of Jaffna. I want to extend our warm welcome to you. So Dr. Kumar he is actually presently the president of the College of Surgeons of Sri Lanka and consultant urologist of the surgeon in Karapatiya Teaching Hospital, Goa. He had his secondary education from Nalanda, Vidyalaya, Colombo, and won MMM, the Goonesinghe Memorial Gold Medal for Best All-Rounder Student in the school in 1981. In 1991, he graduated from Faculty of Medicine, University of Colombo, with second class honours division. Following this, he entered the Sri Lanka postgraduate training program in surgery in 1993 and obtained Master of Surgery MS from the PGIM, University of Colombo in 1997. And chose to specialize in urological surgery and had his training in National Hospital of Sri Lanka and Royal Hallamshire Hospital in Sheffield, UK. Also, he obtained fellowship at the Royal College of Surgeons in Edinburgh in 1999. Further, he obtained board certificate specialist in urological surgery by the Postgraduate Institute of Medicine, University of Colombo in 2000. Took up his first appointment as a consultant urologist in the district hospital, Kurunagale, and spent short tenure in the Annual Teaching Hospital in 2008. Currently, he has been working as a consultant urological surgeon at the Teaching Hospital, Karapatiya, since 2008 for the last 14 years. Along with, he studied Bachelor of Law degree at the Open University of Sri Lanka and graduated in 2008. Called to the bar as an attorney at law of the Supreme Court in 2009. Obtained Master of Arts in Buddhist Studies, that is MA in Buddhist Studies, with merit from the Postgraduate Institute of Pali and Buddhist Studies, University of Kelaniya in 2019. So he is a testimony for lifelong learning in all kind of diverse fields. Besides, he joined the College of Surgeons of Sri Lanka Council in the 2004 during the Professor Mogandi Silva's presidency. Professor Mogandi Silva was orator for last year Dr.Ganesaratnam commemoration lecture. He is the editor of the College of Surgeons Sri Lanka newsletter for 3 consecutive years, brings out 6 issues each year. He was in the council, member of the College of Surgeons Sri Lanka many years, 2004, 2006, 2008, 2011, so on and so forth. In addition, he was a Congress chairman, and presently he is the president-elect last year and the president of the College of Surgeons. He is a very distinguished personality, a person who believes in professionalism. I think in talk he has mentioned that in many places. He believed in compassion. He believed in serving the poorest of the poor. And very fitting personality. And Ganesaratnam sir was a towering personality. He taught our students in a very peculiar way of his art of teaching. He impressed us. And Madam is last year also present, today also present. Our special gratitude for her being with us today. And your presence also, Madam, inspires us. And also our Satish Kumar, he believes in improvisation, and inspiration is okay. But I know Javed Miendat, he improvises. It's very different. So we believe in the improvisation, and today the professional medical profession is all kind of diversity and aberrations, and ethics are the thing we want to learn from some personalities, because that their presence only we learn, not from the books. So I warmly welcome Dr. Satish Kumar Goonesinghe, today to deliver this lecture while I am thanking him for accepting our invitation and being present here today, sir. Now over to you, sir. Thank you.
Thank you, sir, for your kind introduction. Now, our orator will be medaled by Vice Chancellor. Thank you, sir. Next, it's time to hear from our chief guest. I kindly call upon Dr.Satish Gunasinghe, President, the College of Surgeons of Sri Lanka, and consultant urological surgeon, to deliver lecture on surgery beyond the scalpel.
A very good evening to all of you. The Vice Chancellor of the University of Jaffna, Professor Sri Satyanaraja, Dean of the Faculty of Medicine, Professor S. Kumar, Mrs. Ganesaratnam, members of the academic staff of the university, distinguished guests, dear students. I wish to thank Professor Sri Satyanaraja for his kind words of introduction. I'm not sure I'm worthy, but thank you very much. And I bring warm greetings from all surgeons of Sri Lanka, the college representing surgeons of all specialties. We are the college of all surgeons. And the late Dr.M.Ganesaratnam led our college in 2007 as our president. So we represent all the surgical specialties of our country. This is our college headquarters, newly renovated. We celebrated the 50th year, the Golden Jubilee, last year. And this is our part of the college council rules and our annual sessions, which we had just 2 weeks back. And we are the College of All Surgeons, and we bring warmest greetings from the college and the entire surgical fraternity. And on a personal note, I bring warm greetings from all the academics and professionals in the city of Galle, because I happen to be a urologist working in Galle. Thank you very much. Don't worry, these things happen in our lives. So we have to surmount them, as all of us surmount problems in our lives. Thank you very much. So I bring greetings from all of the College of Surgeons and also from Galle. Dr. Ganesaratnam was a great personality. This lecture is held in the memory of a great Sri Lankan surgeon who has made a major imprint in Sri Lankan surgery as an excellent teacher, dedicated surgical trainer, a committed surgeon by excellence, and a prominent national surgical leader. He occupies a special place in the minds of the people of Jaffna and the northern province as a dedicated surgeon who served them with utmost dedication during the most difficult times of their lives. His parents, the late Mr. and Mrs. Vishwanathan Mailu, came originally from Ariala. He had his initial education at Royal College, Colombo, and later moved to Jaffna with his parents and studied at St. John's College, Jaffna. After entering at the Faculty of Medicine, Peradeniya, of the then University of Ceylon, he displayed his brilliant academic progress with excellent results. He obtained 3 distinctions in pathology, microbiology, and pharmacology, the 3rd MBBS examination in Peradeniya. Consequently, he won an exchange studentship to the University of Manchester, arranged by the late Professor Seneca Bibili of great fame. He spent 3 months in the firm of Mr. Anscombe, a brilliant surgeon who may have inspired young Ganesaratnam to take to surgery as a career late in time. Within 3 months of returning to Sri Lanka in 1968, he completed the final MB with 2nd class honours. After graduation, he sat for the primary FRCS and thereafter proceeded to the UK. for his postgraduate studies. He obtained the fellowship of the Royal College of Surgeons of England, the FRCS, in 1976. Dr. Ganesaratnam worked in the St. Heliers Hospital, Surrey, and the Southampton General Hospital and obtained the fellowship in 76. Later, he worked as a senior registrar in general surgery at the Whittington Hospital in London, where he worked in the departments of famed surgeons of the time as Mr. Cochrane, Mr. Russell Locke, and Mr. Alan Watson. And he has also worked as a locum consultant surgeon in Northern Ireland. After returning to Sri Lanka, he spent his next 13 years as a resident surgeon at the General Hospital Colombo, which is now known as the National Hospital of Sri Lanka, and as consultant general surgeon in Marthale and Negombo before being appointed as a consultant surgeon to the teaching hospital Jaffna in 1989. The late Dr. Ganesaratnam worked and provided dedicated surgical services to the people tirelessly under difficult circumstances in Jaffna until 1995. From 1990 to 1995, for a period of 6 years, he was the only consultant surgeon in the Jaffna Peninsula, providing care to all surgical patients, including those with war-related injuries. During this period, he was the only surgical teacher to medical students and the only postgraduate trainer in the Peninsula Jaffna, as the University Surgical Unit was unmanned due to the unfortunate civil war. Today, we are fortunate to have a large surgical fraternity, including specialties in Jaffna, in the hospital and in the university departments. Furthermore, we have extended specialist surgical presence in the Peninsula, in Telikule and Point Pedro. This evening, we remember an academic colossus, Dr. Ganesaratnam, the surgical colossus who single-handedly cared for surgical patients of Jaffna during the immensely difficult period, 1990 to 1995. Dr. Ganesaratnam, this is a picture of Dr. Ganesaratnam with K. Umapathi, the orthopedic surgeon at the extreme right, and S.J. Ratnam and Dr. Ganeshamurthy. Dr. Ganesaratnam moved to the National Hospital of Sri Lanka, Colombo in 1995, where he excelled in his work. He did a spell of training in laparoscopic surgery in the UK. His talents in hepatobiliary and pancreatic surgery and laparoscopic surgery are well known. He was an examiner on postgraduate examinations and served as a member of the Board of Study in Surgery. Even though he moved to Jaffna, he continued links with the University of Jaffna. During his tenure in Jaffna, he was appointed as a visiting lecturer in anatomy and surgery from 1990 to 1995. He was appointed a visiting professor in surgery from 2004 to 2006, and he served in the Council of the University of Jaffna from 1992 to 1996. He led the vibrant Jaffna Medical Association as its president from 1992 to 1994. He has published widely and delivered the Kanagaratnam Memorial Oration on Prevention of Illness and the Sivapathsundaram Oration on Injuries in Children. Dr. Ganesaratnam led all Sri Lankan surgeons as the president of the College of Surgeons of Sri Lanka in 2007. And here we see in this picture, late Dr. Ganesaratnam is late Dr. P.R. Anthony, so he's a surgical doyen of our country, and he's the founder president of our college. And during his tenure as the college president, he led many academic, professional and fundraising initiatives of the college. He also played a key role in the National Committee on Prevention of Accidents under the auspices of the Ministry of Health. Dr. Ganesaratnam was very much a dedicated and affectionate family person. He married his life partner, Nirmala, on 21st of October 1974. All his children, Nisha, Ramana, Pavitra and Ranga are professionals treading along varying paths of accountancy, IT, law and medicine. Dr. Ganesaratnam retired from the government service in 2003 and continued his surgical work in the private sector with dedication and compassion until 2017. Dr. Ganesaratnam left us forever in October 2017. This picture shows he being inducted at the President of the College by Dr. Palibanagala, an event with Mrs. Ganesaratnam, Srinath Chandrasekhar and his wife at the college dinner, and down also we see him actively working in the College of Surgeons in 2007. The history of surgery of Sri Lanka in the northern province with historical facts related to its evolution, facts about Dr. Ganesaratnam, a screen role in Jaffna and in the College of Surgeons have been described in the recent College of Surgeons publication, The History of Surgery of Sri Lanka. A comprehensive 560-page edited by Professor Channa Ratnatunga, Emeritus Professor of Surgery of the University of Peradeniya, one of our distinguished past presidents. On a personal note, as surgical trainees, we were eager to see this great surgeon from Jaffna when we were attending the meetings in Colombo. And he was so very simple, friendly, and his simple safari suit coming to surgical congresses. And we admired him for his surgical prowess and leadership and keenly attended his presentations. In 1993, I commenced my postgraduate surgical training together with 3 of his dedicated former SHOs who worked with him in Jaffna. We started training together on 1st of October 1993. S. Jayaratnam, S. Raviraj, and A. Kailenath. We all started our postgraduate training together. And although we were parallel surgical trainees, 3 of them, Jayaratnam, Raviraj and Kailenathan, were master surgeons, even as beginner trainees, because they had great training under Dr. Ganesaratnam. We were just trying A, B, C of surgery, trying to tie knots when Ravi, Jayaratnam and Kaile worked so very hard and very fast. But we learned a lot from all 3 of them as parallel trainees. And also as postgraduate trainees, he taught us in a very dedicated fashion. Just before exams, we as a group used to go and he used to teach us in Ward 36 National Hospital, and he used to relate stories about York Mason, how he worked, and he taught our surgery a lot as undergraduate trainees. Now, in memory of this great surgeon, I'm going to talk about few things on surgery. And I don't wish to focus on technical issues, as in my specialty of urological surgery, but in general, I will touch on few issues related to surgery. In surgery, we have a past, we have a history, all of us have history. So, evidence of surgery goes into the ancient times of the pharaohs. In pharaonic times, there is evidence that surgery was performed. And in this part of the country and entire Asia, in Sri Lanka, all over, we have about Sushrita and the Sushrita Samhita. His work has been documented in the Sushrita Samhita, and Sushrita, this great surgeon, has described 60 types of upkarma for the treatment of wounds, 120 surgical instruments, 300 surgical procedures, and he has also mentioned about different approaches, incisions, explorations, with specific Sanskrit words in the Sushrita Samhita. And there were monastic hospitals of ancient Sri Lanka. The Lahana Pirivan in Polonnaruwa in the 12th century AD. There were various surgical instruments which were found. And actually this went into the commemorative stamp of our Golden Jubilee. If you see on your right, that shows one implement from the Lahana Pirivan. I'm sure this would have been, these instruments would have been there all over our country, north, south, and all over the world where there was civilization. So these are the only found ones. Then there are the barber surgeons. Because physicians were rather reluctant to perform surgery in the olden times, and in the UK, in England, we see barbers took up surgery. That's why we see the difference. Physicians are called Dr. ABC and the surgeons are called Mr. ABC. So we have a barber surgeon heritage. Then in also Jaffna we had the Pariyara, who were barber surgeons of that time. So where the Siddha practitioners were reluctant to do surgery, these barber surgeons went house to house and they had apparently performed surgery. This type of phenomenon we also see in Europe. And the Royal College of Surgeons have their foundations in barber surgeon companies. So we have some lineage to barbers, and we have to treat them with respect. Modern surgery, now, formerly surgery was considered to be very cruel. When we were kids, when we went to surgical wards, we've seen people groaning in pain and people writhing in pain because they were not given adequate analgesia. So definitionally, surgery means a physical intervention to prevent or treat disease. Prevent, we'll ask that question later. The nature of interventions varies: incisions, resections, reconstructions, transplantations, etc. But of course, there are other nuanced actions that a surgeon would take. But we have to remember that modern surgery is founded on scientific principles. That's the most important thing. We do it based on evidence. Now, human transformation of surgery, one thing from my specialty. On the left, you see how barber surgeons used to cut to a stone. So this person was held, where his legs were held by assistants, and the barber surgeons used to cut directly into the perineum. They used to set a small metal gadget, and they have to sound it. If you hear the sound, they know that there's a stone. There are no X-rays then. Then they cut into the perineum, and they took the stone out. I'm sure most of the patients would have been, they would have not lived actually. But the stone was alive, the patient was not alive. So that is old thinking of surgery. And now you see this another young guy who has come for an extracorporeal shock wave lithotripsy of his stone. So comfortable, listening to music with a beautiful radiographer localizing the stone, so relaxed, going home the same day. So this is the human and modern surgery. This is just a glimpse of it, what we see on the right. But the cruel treatment, but it was not cruel at that time. In history, we have taken a historical context. Things have transformed so much. Patient-centric, comfortable, patient going home comfortably. So there's a role of the surgeon in prevention of disease as well. We think about surgeons chopping off organs, taking away limbs, but the modern surgeon has a great role. I'm sure this is very ABC stuff for my surgical colleagues, but colorectal cancer prevention, these are just examples. Prophylactic colectomies in people with familial disease, polyposis, multiple polyps in the intestines, they are bound to develop colorectal cancers. So we do surgery to take prophylactic colectomy in order to prevent occurrence of cancers. Then breast cancers, there are certain patients with mutations of certain genes, BRCA1, BRCA2, or some familial tendency. Then they undergo prophylactic mastectomy, where the surgeons take away the breast. Angelina Jolie, the famous actress, she is very bold about this. She had she had a prophylactic mastectomy. So this is a key role played seen in this to prevent surgery. So gone are the days of riddance of organs. When we were junior trainees, we saw ectomy, taking away parts of the patients. So they were going without a limb, they were going without an organ, they were having, and even the complications were taken for granted sometimes. But those days are gone now. So ectopic culture has gone. And there's a small eclipse there. Can we sort of the eclipse? And we have excellent pain relief during and after surgery. Gone are the days where people groan in pain. If there is a surgical patient groaning in pain, that is negligence. Any ward, a surgical patient should not be in pain. So if there is pain, that is surgical negligence. Or anesthetic, I don't want to put to any side, pain relief. And current focus is on organ function preservation, function restoration, or organ replacement or transplantation. We try to restore order. We allow patients to be normal as much as possible. And minimal access surgery, I'm not going to talk. You have an advanced minimal access system in Jaffna, advanced laparoscopy. So these things, high-tech things are changing at a vast space. And there's another thing called the enhanced recovery after surgery, very planned surgery. You can plan out surgery and the patient goes home very early. Everything very focused. So ERS protocols are being practiced in some parts of our country. I'm sure all units should take up in selective, especially colorectal, a lot of ERS work is going on. So modern surgery is very humane. They are focused towards the patient. A patient is relatively pain-free and they have good quality of life. So what is surgery? We talk about surgery. What is the definition of surgery? Of course, there is no one definition. As anything for culture, we have hundreds of definitions. There is no consensus. Basically, it entails a physical intervention. Treat disease and the nature of the intervention and can vary in different situations. It's basically a physical intervention. But these are not very clear-cut definitions. So there are blurring boundaries of surgery beyond the scalpel. This is what here in the Government Medical Journal we did an editorial in 2020, Modern Surgery, Dynamic Frontiers and Blurring Boundaries. In this editorial we consider how surgery is in a state of flux, not the traditional scalpel or the cutting. So I happen to be editor of this journal. We did an editorial on modern surgery. Advances in pharmacotherapy has made a change in surgery. So it restricts surgery. So the treatment epidemiology has changed. Peptic ulcer disease, as all of us know, where we used to see as registrars lots of patients with perforated peptic ulcers, bleeding peptic ulcers, but gastroprotectant drugs have reduced the complications of peptic ulcers. Proton pump inhibitors, H2 receptor antagonists, prokinetics, so drugs are reducing, so it's changing the disease manifestation patterns through drugs. So surgeon has a restrictive role now. BPH, in my own field, benign prostatic hyperplasia, prostate surgery was dreadful in the 60s and 70s. Almost they were condemned to death actually, bleeding. But now, with use of medical therapy, the number of prostate surgeries have gone down by 50%. There are alpha blockers, there are certain 5-alpha reductase inhibitors, different drug classes. So drugs are changing the surgical, the picture of surgically, conditions that were amenable to surgery. So things are changing. So advances in pharmacotherapy is one. And blurring boundaries are interventions by non-surgeons. And that's great actually. Coronary artery angioplasty and stenting. That was we know, all of us know. And atrial septal defect closure by cardiologists. They are doing physical interventions, but they are intervening physically on a disease. So they are, we can't say they are infringing our territory, but they are progressing. So we all, these are not kingdoms, surgical kingdom, physicians' kingdoms. There are no kingdoms anymore. We all work together. So cardiologists, with all respect, they are doing a great job putting stents, saving lives, PCIs. Then interventional radiology, we all know, is a revolution. What they are doing, saving lives. So there are these are blurring boundaries. Pharmacotherapy, interventions by others, causing blurring boundaries. So role of surgeons in disease management is being redefined with these changing boundaries. The approaches and scope of modern surgery are ever changing, expanding, and evolving even today at this very moment, like any field of science. Even surgical repertoire, the choice of procedures that we have to do for a given situation is changing. What we did today may be not very modern, but when you are taking modern, you are thinking about cost efficacy, whether a country like ours can afford these type of things. In some situations, the place of surgery has been taken over by medications and other interventions, as I told you. Next, I move the next part of my lecture, surgery going beyond the scalpel, the quality excellence of the surgeon. Whatever our vocation, be a surgeon, a medical doctor, administrator, an accountant, whatever, we need work excellence, quality excellence. That is something which we all should have. Basic relationship where we have with the patient. Now, we all can fall ill. It's a disease, an illness, informed, all are almost synonymous, but it's the illness relationship that we see. So, there are different components. The fact of illness, we all know that we have a illness, but it puts the patient and a doctor in an unequal relationship. Doctor is superior. When we were small, we thought doctors were demigods. I'm not sure of that. But we thought doctors were doctors and they were great. But it's no longer the case. So this is an unequal relationship. We will ask, doctor, what will you do to me? Can you help me? So doctor is at a higher level. And we do an act of profession. So legally we implies a promise to help the person. That's to treat. Then there's an act of medicine, either to give medication, do a procedure, or to do surgery. I'm sure those are the three basic steps in the healing relationship. To quote from one of my colleagues, Arosha Disanayaka, the current president of the College of Physicians, of Ceylon College of Physicians, in his inauguration address, he said, technical prowess, analytical thinking, effective communication, and resilience. Those are the greatest features a doctor should have, not a mere stethoscope and being sort of a demigod look going in a tie with a briefcase. That's the normal look we think of a doctor. But a real doctor should have a technical prowess, analytical thinking, effective communication, and resilience to the world. These are not my words, actually these are great words from my physician colleague. Technical prowess is you have to have up-to-date knowledge about the disease conditions and their treatment, continuing medical education, and practicing what we learn. That's the most important thing. Then bedside clinical examination skills. Nowadays, we don't see much in some bed tickets when we see. Because sometimes they don't document adequately. This is a national or international phenomenon. So, we go on investigations in a slavish fashion. Now, I don't condemn modern investigations, but they should be done with justification and with a very clear idea as to what we do. In some departments, blood tests are ordered, but they never check back what the blood tests are. Not all. They may be a minority, probably. But bedside clinical examination is one of the most important areas that we should focus on. Not just what's wrong with this patient, that's not the round you have to do. We have to examine each patient, talk to each patient. In our department, most of our departments we do, I'm sure. Who is this guy? That's not the test. What's wrong with him or her? Talk to him, examine him. Even the few minutes, it takes time, but that's the best thing we can do. And ability to perform well-reasoned and focused, relevant, appropriate diagnostic or therapeutic procedures. We are just ordering investigations. You have to reason yourself Why am I doing it? What information do I need? So technical progress is a must in a clinician. Otherwise, we become somewhat failures. Analytical thinking. Rather, sir, this patient has been admitted today. He is past history of appendicectomy and not that type of presentation. So, doctors, we have to analyze. Ability to understand, solve complex problems by analyzing them to where I had a comprehensive diagnosis. Analyze. And so, from a junior level. Now, we were taught by Professor Sharif, the professor of surgery, when we were students. First, ask yourself what is the problem or what are the problems in this patient. Then he used to ask ourselves, what is the priority of these problems? Then he'll ask, yes, gentlemen, what is the short-term plan in the management and what is the long-term plan in this patient? Then he used to cover the entire management of the patient. Otherwise, your history is taught. I mean, he was very strict on these things. So we have the ability to understand, solve some complex problems by analyzing. Determination of the most suitable investigations and institution of patient-centered care. We don't treat a disease, but as we all know, we have to treat a patient with a disease. Sorry, sometimes I'm talking the truth, but this I found in technical prowess, analytical thinking, and effective communication. That is also a problem with the emperor consultants or empress consultants. They just come like say in a Dandumunara or a vehicle and they don't communicate. All these problems happening in the wards are due to lack of communication. Or you think we are sort of demigods or just above God. That can't happen. Effective communication should be with the entire team, the patients, how we look at patients, how we smile and put them at ease, how we listen to their stories and not merely take histories, being empathetic, get into his boots and we think what we had to do, being able to understand how patients think and feel, and being a friend to them. I mean, that doesn't mean that you are going to be friendly and talk gossip with them, but that's what I would expect from a doctor if I am unwell. So we have to think to ourselves and effectively communicate. It has to be appropriate communication depending on the patient's situation. And even informed consent, which if I go to talk about informed consent, that's a long topic. And also how you communicate with co-workers, work-related communication. All levels of staff, colleagues and other specialties. You need not be soft, but you can be tough, but you can be gentle. Reprimands you can do, but it has to be done in a proper way with embarrassment. Most conflicts have their origins in poor communications, tale carrying, gossip, and a lot of things. So communication is two-way, patients and the co-workers. In a difficult situation, we all experienced the COVID-19. We all were caught in this unfortunate war. We had only one surgeon between 1990 and 1995 in Jaffna. This is the resilience of the people, isn't it? The professionals, how people were looked after. Dr.Ganesaratnam is a great example for resilience. He held fort altogether. As the Vice Chancellor said, when others wanted to close down the faculty of medicine, Dr. Ganesaratnam stood fast and he was resilient. And today we have a fully functional faculty with advanced departments. So it's a capacity to survive a crisis. There's, in medical practice, there's no words called no and can't. That should be taken away from our vocabulary. There's nothing called no or nothing called can't. Yes, we can do. We'll try to do. That's what we have to do. That's how we have developed our departments. Resilience is not much just survival, just passive survival. You just wait and by God willing or whatever the divine force willing, we come out. No, we come out stronger. We come out with new methodologies to develop. Create a set of skills. Create the ability to face. Like the Zoom and or the online platforms came into being with COVID-19. So we have come out with new ways of doing things. New ways of scheduling patients. So resilience is not just passive resilience, but active resilience. And it is nuanced also in surgery, institutions, pandemics. So resilience is something which is very important to us as surgeons. Going beyond the scalpel, we will have the MS FRCS, but we should be resilient. We should have the technical prowess. We should have the analytical thinking. And surgeon's role in patient care transcends, it goes across the traditional role of assessment and mere performance of surgery. If you are merely performing surgery, we become surgical technicians, but we have to be sort of very empathetic physicians, surgeons. So there are multiple roles of the surgeon. I'm just going to touch on these. Professionalism, compassionate leadership. I'm so very sort of passionate about compassion, improvisation, innovation and development, amenability and adaptability, and surgical research. Now these are 5 important areas that as not only as surgeons, as clinicians, as doctors, as academics, we should have these. I'm making restatements, pardon me if I'm doing it, but these are very important facts. Professionalism is utmost dedication. There are so many definitions. Focused and purposeful planning, identification of the clinical problems and their priority, as I told you before, and focused and purposeful treatment. So we have to be very professional when we work, not because patient A is someone, patient B is the president's brother, patient C is prime minister's nephew. That is immaterial to us. We should treat all patients alike really well. So all patients, that's most important, utmost dedication. So major domains of professionalism are, I have not got the time to talk, knowledge, skills and performance. All these words have a very deep meaning. Safety and quality, communications, partnership and work, and maintenance of trust. The patients, poorest of the poor, richest of the rich, will come to a doctor reposing trust on him. So that trust it's not a contractual trust, but it's a trust reposed as a human being. So that's very important to maintenance of trust. Now there are so many attributes of professionalism. I'm not going to talk far. Altruism, accountability, all these are in the GMC guidelines. Respect, integrity, submission to an ethical code, lifelong learning, honesty, compassion, excellence, systems. So these things are actually, though these attributes are there, if you realize reflect yourself very carefully, that amounts a human core values. I mean, we didn't have these type of lectures when we were students, but we subjected ourselves to good role models and human core values. I mean, these lectures are not, I mean, if you think whether what I am doing is wrong or correct, that's the most important thing. Have a tap here and see whether I are doing the correct thing. Will I do this to my mother or father? Then everything will fall. This lecture is not required if you think that way. Then good doctors make their care, this is very important, care of their patients is our first concern. They should be competent. So competence comes there. They should keep their knowledge and skills up to date. We can't say these are modern things, these are out of us, we can't tell. We have to keep ourselves up to date. They have to establish and maintain good relationships with patients and colleagues. So that's also parts of communication. And they are honest and trustworthy. So honesty and trust are very important attributes. I'm sure you all are. And act with integrity. Have your integrity. Take decisions. That's impossible. Coming to the second attribute, compassionate leadership. Compassion is a universal human value. Patient care is founded on compassion because we are bound to care for the sick. So compassion should go across all boundaries, ethnic, religious, national or whatever, to all human beings. And compassion is something which has to come from within us. So compassion and compassionate leadership are very important in this context. In classical Hindu literature, compassion is a virtue with many shades, each shade explained by different terms. Daya, Karuna, Anukampa. There are lots of Sanskrit words I came across when I was doing reference. So it has a basis in Hinduism. In Buddhism, Karuna or compassion is considered as one of the key four sublime states, others being loving kindness, altruistic joy, and equanimity. So there are Hinduism, Buddhism talks about it. In Christianity, the numerous biblical references refer to the compassionate God and compassionate people. So there are many biblical references on the compassionate God and compassionate people. In Islam, the concept of mercy is connected to compassion. It is held that mercy of God and His compassionate nature encompasses and envelopes all the people. So we see the concept of compassion transcends all religions, Hinduism, Buddhism, Christianity, Islam, for that matter, all the religions, major religions of the world. And compassion should be all around. Patient care settings is nuanced. We know all of us have to be compassionate towards all. And it is a cognitive empathy. We have to have a cognitive empathy. These are not artificial things, it should come from within. It's a cognitive empathy. We all are compassionate towards our patients during different types of encounters. We have a broader concept of compassion to colleagues, peers, all team members, and the community at large. May I quote from an excellent speech delivered by Professor Rohan Jayasekara at our inauguration of the annual sessions. He is Emeritus Professor of Anatomy of the University of Colombo. I quote, "Objectives such as physician-patient relationships and the practice of respect, dignity and decorum between colleagues, just to name a couple, are important in empathy. But frankly, this component on the assessment of human values needs to be revisited and should be more intricately woven into the training of surgeons. Simply ticking off of boxes in a checklist in the assessment form of trainees regarding the aspect of professionalism may not suffice. Perhaps the assessment form needs another careful tweak, introducing a more focused system of grading by example and close monitoring. It should include assessments of their social and professional networking skills, peer etiquette as mandatory requirements. The responsibility of achieving these objectives, needless to say, is with the trainers and the College of Surgeons. The aspect of mentoring also must be raised to another realm. Role models need to be more visible. They are visible. And real and accessible to the trainees. This will leave lasting and precious impressions in the minds of their mentees. We have a treasure trove of role models in the College of Surgeons. I'm very proud of that. Conscript them, mobilize them, or even abduct them, if you want. Request them to assist in the laudable quest of compassionate surgery. I think that goes over surgery, medicine, all our vocations, compassionate professionals. And he concludes, the trainees on the other hand should appreciate and accept the importance of these basic needs in their professional lives and be thirsty to accept and acquire these values from their seniors. They must be convinced the skills alone will not sculpt the surgeon who conferred demigod status, the one the profession and society yearns to have. So it's not mere skills, ticking boxes, but it should be compassion, behavior all around, all our jobs. So as leaders, we have to be compassionate. We are bound together and creates a sense of safety and interconnectedness. So compassionate leadership causes improvement of staff well-being, improves patient experiences, and improves patient outcomes. If the team is happy, people work happily, and outcomes are better. If the consultant comes, all will smile, and within them, if they hate the consultant, this useless guy is coming to bother us and shout at us, oh, and they'll be doing that. and they'll be cursing the consultant within them. But if it's a compassionate consultant, they'll love him, they'll help him, they'll work together. But being compassionate doesn't mean that being very soft, honey, can I do, not that. You have to be tough, but good and compassionate. So a lot of people misunderstand compassion as being soft. It's not being soft, firm, tough, purposeful, and compassionate. So that gives us a lot of excellent team spirit and good outcomes. A lot of work on this has been done by Professor Michael West. He's a professor at the University of Lancaster, and he has written a lot on compassionate leadership. And also Professor Jackie Taylor, immediate past principal at Royal College of Physicians and Surgeons. She has done a lot of work on this. You can read a lot on the net. I had the fortune of meeting Professor West and Professor Taylor and exchanging ideas on these aspects as well. And these are quite relevant to us. So you are attending, you are empathizing, you are understanding, you are helping. In compassionate leadership, you are involved in the teamwork. So it's very important. We all realize teamwork is so very important. Compassionate leadership is inclusive, enables all to feel have leadership responsibility. That is very important. And effective leadership harnesses excellent outcomes in the patients. This year, our Congress featured, our theme was compassionate surgery. And here we see Aloka Patirana is the professor of surgery in Jayawardenepura, introducing an orator. And lower, you see, we had a surprise. Lote Shering is the Prime Minister of Bhutan. And the other special thing about Lote Shering, he is a consultant urologist, just like me. And he practices urology during the weekend. And he delivered an excellent live address to I just sent an email and he accepted it. And he addressed the college surgeons, I think Rajendra and a lot of them were here. And this was the Prime Minister of Bhutan, who was a surgeon, addressing to us, and for his talk showed that he is not a politician. He said he left the scalpel for the pen to make policies for the people of his country. And this is Dr. Lote Shering appearing at our college inauguration. That was a real surprise for most of us because coming from a practicing surgeon. So this time compassion was flowing in our Congress. I hope that compassion will flow into practice all around our country. Then briefly touch on improvisation. In our part of the world, we have to improvise, innovate, develop. When I came as a urologist, I was the 6th urologist in the country. We didn't have facilities. We didn't have urologists Jaffna. In Kurunangal, I had to cover up Jaffna, Vaunia, Trinco, Batiklo, and all the major cities, and the urologists in Kent. We also shared a lot of work. So now we are so happy. We are more than 40 urologists serving all around the country. You are so fortunate with 2 urologists in Jaffna. So that is excellent. So you have to adapt according to the local environment. Initiation and development of new surgical units. I think that's what's happening in Jaffna. With JICA projects, you have got excellent equipment. All over the country we have development. But nowadays, of course, there is a backward migration as well. Improvisation. We'll have to improvise according to the needs, the prioritization. For example, when I was in Kurunangal, we had our cystoscopy, flexible cystoscopy set up in the clinic itself. So if a person came with hematuria, blood passing in the urine, immediately that patient had a flexible cystoscopy in the clinic, and we had an understanding with the radiology department. Within 1 hour, ultrasound scan was done. So by 11 o'clock, he was sorted. But that is not the case in our hospitals. Patient has to come in a queue. So he has to be in the clinic queue. If he has a known attendant or someone, he will come before all of us. If a known consultant there, the patient will come out of the queue. So then the poor patient goes and he gets a blasting by the doctor and the form is filled. Then he goes to the Department of Radiology and they give another date. Then the poor guy has to go again. Then he comes again to the clinic. Then he has to go to the clinic again to show the reports. Then he has to come again. Lokumatya is not in the clinic, the Periyadore is not there. Then Periyadore has gone somewhere, and like today, I'm here in Jaffna, today's morning was my clinic. So then he has to go back again. So that is really arduous in our country. So try to make it patient friendly. It's difficult. It's difficult to break the ice. But we can try in our small ways. Sometimes I write in my form, can you please give a date on Monday morning to coincide with the clinic? So they give a date on the same day, he gets the scan and come back. So you go the extra mile. Now in Gaul we know there are buses coming from Abilipitia, Sevanagala. I know the bus times also. So like that you have to know bus times. You're not supposed to shout at me saying that you know the bus timetables from Jaffna and the Jaffna station. For higher than 11, you will shout at me. But it's not the case. Try to go the extra mile to help. But sometimes they'll write on you. So you have to be careful also. Sympathetic, empathetic, but not emotionally involved. We can't get emotionally involved. And sharing of units and resources is a very sensitive point in our country. But if there are multiple consultants, to peacefully share as much as possible. And further develop the existing units. Now in Jaffna we see surgery has expanded so much. We have advanced laparoscopy. So like that, it's the person's innovation, your enthusiasm to develop. So that's another important thing of a good surgeon. Unfortunately, this slide now, this is the royal, just one example, 30 seconds. In Australia, there's a royal flying doctor service in Australia. So if a person falls ill in a remote location, they are airlifted to key cities. If there's a patient who is awaiting a heart transplant or renal transplant, the key city is lifted to the other key city by the royal flying doctor service. And they give the furthest corner the finest care. Wherever you are, if you are from a faraway island, let us say in Delft, or a fisherman comes to Katchathu and falls ill, then still we'll have to give the best of care in the nearest hospital. So furthest corner, finest care should be our thing. So we are so proud in Jaffna the facilities that are developed. So all other parts of the country, facilities are developed. So we should work with motivation to provide those facilities. And amenability and adaptability. Once we land from one of the advanced centers in the UK or America or Australia, we try to be sort of white, we have a white exterior, but we tend to be sort of, sometimes where I work we had all the facilities, but here we don't have anything. That's also bad. So amenable, adaptable, develop. Local situations, wars and disasters in Jaffna we have experienced. In pandemics we had adaptability. We had to adapt. As surgeon, as a researcher, this is a final thing. Research is a key element. Now this one area we tend to neglect. In the university departments I'm confident that it happens. But all have to be encouraged to perform research. Simple to complex studies, clinical audits to randomized controlled trials. There's a vast range. But research can happen at different levels. And there's an active role for us as professional bodies, universities, the National Science Council. Unfortunately, we don't have funding at the moment. It's a major problem everywhere. But funding is a major limiting factor in our country at the moment. But we have to be researchers. I am proud to say our college has a surgical bibliography. First we published a print version edited by, once again, Professor Jaffna. It was a print version where he listed all surgical publications by Sri Lankans over 150 years. But we thought it has to be dynamic and updatable. Now we have a fully functional surgical bibliography online, where we can update, people can search. So if you want to do a study and you want to study a certain particular surgical topic done in Sri Lanka or by a Sri Lankan, all these are accessible online free of charge. It's altruistic service by the College of Surgeons. So it's available for anyone to access. The surgical bibliography of Sri Lanka. So once again, a good surgeon is a doctor par excellence, playing multiple purposeful roles. With technical prowess, analytical ability, effective communication, and resilience. And we have multiple roles as surgeons beyond the scalpel towards excellence, professionalism, compassionate leadership, improvisation, innovation and development, amenability and adaptability, and surgical research. So, in conclusion, I must say, we remember and celebrate, we remember and celebrate the life of Dr.M.Ganesaratnam, MBBS, Ceylon, FRCS, England. And he was an excellent clinical teacher. He was a dedicated surgical trainer. He was a committed surgeon. He was a national surgical leader. We can proudly say that he was a true surgeon who displayed professionalism, compassionate leadership, improvisations, amenability, development and engagement in research. He also possessed key attributes of a good doctor: technical prowess, analytical thinking, effective communication, and resilience. The greatest tribute that we can pay to this great surgeon, Dr. Ganesaratnam, is to emulate all his great qualities and become compassionate and committed surgeons, clinicians providing clinical excellence to all our patients at all times. I wish to thank the Vice Chancellor, the Dean Faculty of Medicine, University of Jaffna for inviting me to deliver the lecture, and also wish to thank my dear colleague Professor S. Raviraj and Dr. Gobi Shankar for their kind help and facilitation of this lecture. And this particular hall, the Hoover Auditorium, brings to me some personal memories. When we were raw first year students in 1982 October, Professor Hoover was doing work in the University of Colombo. Again, I think the university here. And I still have his tutorial marks. He was signed nicely as A.A. Hoover. That was in 1982. I'm a sort of a museum specimen. So I still have his notebook signed by Professor A.A. Hoover. Then we had our senior lecturer in biochemistry, Professor Dr. K. Balasubramanian then, and he taught us biochemistry before moving as the chair professor in biochemistry in the early 1980s. So we were taught by Professor K. Balasubramanian as well in Colombo. Then also S. Raviraj, who was the dean of this faculty, Professor Raviraj, we were colleagues together as parallel trainees from 1993. So 3 deans, I've had different types of relationships. And the great Professor Kanagasundaram, for the Professor of Anatomy, another demigod we looked up when we were looking as students, for all his work in the development of the lesser sac. And he is quoted in the Gray's Anatomy. And they are great products and they are great parts of this great heritage of the University of Jaffna. Thank you very much for inviting me. And I hope I have stimulated, depressed, or I don't know what I have done to you, but to be compassionate and good surgeons, clinicians, everywhere. Thank you very much. Now I have a special presentation to make to the Vice Chancellor and the Dean. This is the history of surgery of Sri Lanka. I am not a bookseller, but this is the epic work done by Professor Chandaratnatumba, Emeritus Professor of Surgery in Edin, and it documents all the development of in surgery, what happened all over the country, including Jaffna. Account about Dr. Ganesaratnam, and this I wish to present to the Faculty of Medicine Library, to both of you, sir. And also will be a presentation to the public library of Jaffna and to the people of Jaffna as well from our college. for them to read about the history of Sri Lanka. Thank you.
Thank you, sir. It's a great honor to have you today in this Memorial Day. Your word and presence made our day. Now the certification of appreciation will be given to our orator by Dean Faculty of Medicine. Thank you, sir. We have almost come to the end of the ceremony. To deliver the vote of thanks, I kindly call upon Professor R. Surendra Kumaran, Dean, Faculty of Medicine. It's my great pleasure and honor to thank the orator, Dr. Satish Kumar Goonesinghe, the President of the College of Surgeons of Sri Lanka, Consultant Urological Surgeon, Pediatric Hospital, Goal, Sri Lanka, on surgery beyond the scalpel. Thank you, sir, for being here in person in Jaffna to deliver the oration in spite of your busy schedule. I know how you are busy and have a various responsibility as a president of college and a surgeon. We have done and agreed to be here physically and all the way, come with your wife, and we are appreciating your commitment to be here as an orator. And the oration is very appropriate and honor to the great surgeon who dedicated his life to the field of surgery and was a humble humanist with a skill to cure many people. I would like to thank Vice Chancellor Professor Sri Satkunraja for his support and guidance to organize the oration. His commitment to supporting the oration is remarkable. Many activities are happening at the university at the same time. The Vice Chancellor allocated the time to organize the oration. Thank you, sir, for your continuous support. I also would like to thank that Mrs. Ganesaratnam and their family members for their continuous support and the commitment to facilitate this oration and also attending here physically. I also thank the distinguished guests from various departments and organizations for the participation in the oration physically and remotely. My thanks goes to council members, former vice chancellors, present and former deans, and academic supportive and non-academic staff for attending the sessions and also contributing to organize the event. The event is impossible without the support of the essential staff of academic and staff, the head and the staff of the Department of Surgery and the Office of the Dean, Faculty of Medicine. I thank all for the participants to grace the occasion physically and online. Finally, I would like to thank all people who have contributed to the success of the event. And thank you so much.